Today, we start two new topics. First is drugs in pregnancy. Up to 95% of women take 4 or more drugs, not counting vitamin supplements at some stage during pregnancy. There are two major considerations regarding drugs in pregnancy. First, the effect that the drugs have on the pregnancy. Second, the effects that the pregnancy has on the drugs. And you can see case about a woman with her child, and why we must treat from individual treatment. The majority of drugs attain concentration in the fetus similar to those of maternal plasma. It's important to remember that approximately up to 5%
Recording in progress.
Hello, Professor. Good afternoon.
Good afternoon. I continue, and after stopping lecture, I send this lecture. Okay?
It's okay. Understood.
Okay. So it's important to remember that approximately of 5% of all live births associated with fetal abnormality. Drugs to be responsible for only 1 or 5% of this. Association doesn't necessarily imply causation. Exposure during the first 16 weeks of pregnancy associated with increased incidence of physical malformation. However, less obvious effects such as decreased neuronal function, impaired intellectual development may occur following exposure at any time during pregnancy. Teratogenicity. This is difficult to predict prior to marketing. Information comes from retrospective studies and animal data, often unreliable. The FDA classifies drugs in increasing order of potential toxicity. Next, pharmacological risk. Zero risk, there are generally predictably based of the no pharmacology of the drugs. For example, non-steroidal anti-inflammatory drugs may cause premature closure of the ductus arterius in the later stage of pregnancy. At term, excessive effects, for example, tricyclic antidepressants, and withdrawal syndromes, for example, opiate, selective serotonin reuptake inhibitors, may be seen in neonates following maternal use. Clearance. Pregnancy is generally hyperdynamic physiological state. Drug clearance may be increased, whereas it be via renal elimination or liver metabolism. The maternal cardiac output increased by up to 30% during pregnancy, increasing the renal blood flow and glomerular filtration. Right? The hormonal state in pregnancy also associated with enzyme induction of some drugs. Maintenance doses of drug often need to be increased during pregnancy to compensate for increased clearance. Volume of distribution of pregnancy may be increased by 20% for both lipid and water-soluble drugs. Increased loading doses may be required because of an increase in both body fat and water. Protein binding, maternal albumin concentration decreases pregnancy to a low at term. Measured drug concentration of highly protein-bound drugs may be low, but this is usually unimportant as free concentration are not affected. Assessment requires specialist advice. And you can see different status of pregnancy. Pregnant woman has difficult pharmacokinetics from different drugs. Sometimes weight toxical effect, sometimes absent pharmacodynamic effect. Special types treatment with using antibacterial drugs, for example, penicillin, safety drug for pregnancy, but a therapeutic concentration in fetal tissues increase. Macrolides, not toxical, but we must remember about hepatotoxic effect. Erythromycin, bad drug for pregnancy. In first and second and third trimester of pregnancy, woman has a different status of pharmacokinetic for different drug. All drug increase risk of embryotoxicity. I send this information. I'm not to read these slides. It's short about different group of drug. Yeah. If woman has treatment with anti-epileptic drug, before pregnancy, we used 2 or 3 drugs together, but if we have pregnancy woman, we must use only 1 drug with minimal dose for effect. 1 drug decrease risk of teratogenic, embryotoxic, fetotoxic effects. If woman has arterial hypertension, doctor to use only beta blockers for treatment arterial hypertension, but must remember about side effect for baby after burn. It can be loss weight baby. For women with diabetes mellitus, we to use only insulin. And I want to tell about classification of drug for pregnancy. You can see several categories, A, B, C, D, and X. Category A. There are drug-controlled studies in animals and women and haven't any risks. Category B. Animal studies have not shown risk, but there are no controls studies, clinical studies in pregnant women. Animal studies have shown risk, but controlled studies in women haven't. For example, it's paracetamol, antibacterial drugs, a group of beta-lactams, methyl-dopa for treatment arterial hypertension, non-steroidal anti-inflammatory drugs not using in third trimester, and other time, please, it's sulfate drugs. Next category, category C. Animal studies have shown risk, but studies in women haven't done so. For example, antipsychotics, most cardiac drugs, antihistamine drugs. Next, category D. Positive evidence of some human risk exists, but benefits may in some circumstances outweigh risk. As for example, ethanol, anticonvulsants, warfarin, tetracycline, diuretics, lithium, antidepressants. And last group is category X, too dangerous, contraindicated for pregnancy. For example, vitamin A analogs. This thalidomide, drugs for treatment oncology disease. This all drug have cytotoxic effects. I sent this table. And second topic for today, the risk and benefit ratio must be considered when drugs are used in pregnancy. Avoid all drugs if possible, including social drugs, for example, alcohol, caffeine, nicotine. Avoid drugs in the first trimester, all drugs in first trimester. Choose drugs of proven sulfate least toxicity. Choose sulfate drug. And use short courses and the smallest doses for women. The breastfeeding during maternal ingestion of even small drugs, so small amounts of some very toxic drugs, is probably not wise, even if the likely concentration in the infant is low. For other drugs, an arbitrary decision has to be made as to safe concentration in the infant predicted infant plasma concentration of 10% of maternal concentration. They used cool-off point. I send this information. Most drugs pass into milk by passive diffusion of the free and ionized form. They are distributed within the aqueous, protein, and lipid phases of milk. milk contains more fat and less protein than blood. Therefore, drugs that are highly lipid soluble with low protein binding and unionized at physiological pH achieve higher concentration in milk. Few drugs have concentration in milk higher than those of maternal plasma. And the risk to the infant of medicine ingested via maternal milk may be considered from three viewpoints: the dose of medicine ingested by the infant, the resulting infant plasma concentration, and the potential toxicity of that concentration. The most commonly used index that enables the dose to be calculated in the milk plasma ratio. The most valid milk plasma ratio is that base of the AUG of drug and milk compared with AUG in maternal plasma. The milk plasma ratio enables the concentration of the drug in milk to be estimated from knowledge of the maternal plasma concentration maximal. The infant dose be estimated from the maternal plasma concentration, the milk plasma ratio, and the volume of milk ingested 150 milliliter per kilogram per day. Dose infant is concentration mother, MP milk plasma, and volume milk. Beta index of dose is the actual amount of drug present in the milk over the maternal dosage interval. The infant dose can be put into clinical perspective by comparison with the maternal dose or with doses used therapeutically in the infant. The weight adjusted at maternal dose is the dose the infant receives via milk compared with the mother's dose corrected for respective weights. It's usually expressed percentage. The infant plasma concentration, this depends on the dose rate, the oral availability, and the drug clearance in the infant. F is usually assumed to be equivalent to other adults, although this may not be so. Drug clearance is considerably in parity in infants less than 3 months of age, and especially so in the premature neonatal. And approximate values of clearance at different ages that enable calculation of appropriate concentration in infant shown below. General advice regarding drugs and milk, you can see in slide. Is avoid drug if possible, weight up the risk or benefit ratio, exercise more caution with toxic agents, feed baby just prior to the next dose, alternate breastfeeding with bottle feeding to decrease possible exposure. And drugs considered to be safe when breastfeeding full-term healthy babies. This table is a guide only, consult experts readily. and drugs considered to be unsafe during breastfeeding. Mhm. You can see case. Answer. For this case, we must to treat the mother and choose safety status for child. It's must be transferred to artificial feeding. The next topic for today, clinical pharmacogenetics. Some pathways of drug metabolism affected by genetic polymorphism with marked dosing implication, fast or low acetylation. Acetylation is phase 2 conjugation reaction catalyzed by N-acetyltransferase. Among Caucasian, approximately 50% fast and 50% low acetylizator. Acetylization status determined by parent metabolite reaction in the plasma or urine. Drug affected by acetylator status include pracainamide and, for example, hydralazine, increased risk in slow acetylators. Sulfonylamides, increased risk of hemolysis in low acetylizator. Isoniazid, increased risk of peripheral neuropathy, increased risk of hepatotoxic. Next, glucuronidation. The other major phase second reaction is also subject to genetic polymorphism. Patients with Gilbert's disease have deficient glucuronyltransferase deficits. This enzyme reflected by higher bilirubin concentration. Algidrid dehydrogenase. Around 50% of persons of Mongoloid descent have algidrid dehydrogenase deficiency. They are unable to metabolize acetyl produced from ethanol and may develop sulfuram reaction. Build-up of acetaldehyd causing flushing and vomiting. So next, pseudocholinesterase deficiency. 1 in 3,000 individuals cannot metabolize succinylcholine and require artificial respiration for some hours after succinylcholine uses, for example, during anesthesia. Next form, thiopurin methyltransferase. Azathioprine and its metabolite 6-mercaptopurine metabolizate a variety of active and inactive products. In patients with thiopurin methyltransferase deficiency is shunted down alternative pathways, increasing both efficacy and adverse effect, especially bone marrow depressing. 1 in 300 Caucasian SN30 without thiopurin methyltransferase activity, while 10 persons have intermediate activity. Dihydropyrimidine dehydrogenase. 5-fluorouracil is metabolized by dehydropyridine dehydrogenase, DPD. Absolute and partial DPD deficiency occurs in around 3% of the Caucasian population, and in this patient, excessive toxicity may be observed. And next, cytochrome P metabolism. The most important is the forms for drug metabolism, cytochrome P3A4, 2D6, 2D19, 2C9, 1A2, and 2E1. Of this, only 2D6, 2C9, and 2C90 have clear-cut and clinically important genetic polymorphism. More will undoubtedly be found, however. Cytochrome P enzymes polymorphism. The first evidence of polymorphism was the discovery of slow hydroxylation of spatin and debrisoquine. Both are mediated by cytochrome. Around 40% of cytochrome metabolism is carried out by polymorphic enzymes. Interestingly, the Meyer cytochrome group, cytochrome P3A4, doesn't appear to be subject to genetic polymorphism. And cytochrome status may be determined by examining the phenotype, metabolic ratio, or the genotype. The metabolic ratio is the ratio of the parent drug to the metabolism. CYP2D6. Homozygous and heterozygous excites with appropriate fast and intermediate metabolic ratios. Total absent of the gene resulting in slow metabolism. There may also be gene duplication or multiple copies resulting in ultra rapid metabolism and very low drug concentration. 5 to 10% of Caucasian and 3% of Mongoloid, Polynesian, and Negroid people are poor metabolized. Clinically relevant example of cytochrome 2D6 poor metabolism include perhexylin, neuropathy, liver toxicity, fenformin, lactic acidosis, or timolol, eye drops, systemic beta blockage, flecainidine, arrhythmic dis. Codeine requires cytochrome 2D6 to be metabolized to its active metabolite morphine. Since poor CYP2D6 metabolites have no active CYP2D6 enzyme, codeine doesn't relieve pain in this patient. CYP2C9. Around 3% of patients on warfarin require only around 1 milligram per day for clinical anticoagulation. Mean of 7 milligram per day normal metabolism due to poor metabolism. Next enzyme, CYP2C19. 18 to 23% of Mongoloid and 3 to 5% of Caucasian and Negroid people are slow metabolizer. Area under the curve AUC of omeprazole, a proton pump inhibitor, increased around 12-fold in patients with slow metabolism. And next enzyme, characteristic of major cytochrome drug metabolism enzymes, cytochrome PEM enzymes, essential for the metabolism of many drugs. So this class has more than 50 enzymes. 6 of them metabolize 90% of drugs, with the 2 most significant enzymes being cytochrome 3A4 and cytochrome P2D6. Genetic variability, so it's polymorphism. In these enzymes may influence a patient's response to commonly prescribable drug classes, including beta blockers and antidepressants. Cytochrome P enzymes can be inhibited or induced by drugs, resulting in clinically significant drug-drug interaction that can cause unanticipated adverse reaction or therapeutic failure. Interaction with warfarin, antidepressants, anti-epileptic drugs, and statins often involves the cytochrome enzymes. Knowledge of the most important drugs metabolized by cytochrome P enzymes, as well as the most potent inhibiting and including drugs, can help minimize the possibility of adverse effect reaction and interaction. So genotype tests can determine if patient has specific enzyme polymorphism. It has not been determined if routine use of these tests will improve outcomes. So it's all.